make much difference. The reason why I postponed it, or why I preponed it for, this lecture, is because the lecture number 3 is very extensive. It's even though it is only like 50 slides, but it is the hardest, and it will take more than 1 hour easily. So this, inshallah, we will do on Wednesday. And there is no problem in sequence because they are not out of sequence. They are the same materials, looking at it from different angles. All right, so here we'll talk about actually how cancer come to happen. So by now you have known that actually cancer is a genetic disease. It is a genetic insult that is either happening, sporadically, acquired, if you will, by, for example, environmental kind of insults such as radiation, or it is happening as a result of heredity. It's being inherited from mother to offspring, from father to offspring, and so on and so forth. At the end of the day, it is the genetic material that is undergoing this insult that is resulting actually in the carcinogenesis. Not every genetic insult is going to result in cancer. Not every mutation that the cell is exposed to or the cell acquires is going to result in cancer. As a matter of fact, actually, the vast majority of mutations and translocations and breaks, if you will, genetic material breaks, will not result in anything. It's simply the cell will die. The cell will not be able to replicate, and the cell, as a result of that, will die. In this very small, tiny minority of cases where this mutation is going to be arrest of maturation effect. In those circumstances, then it's possible that this cell may give rise to tumors. Okay? So it is really a matter of, I don't want to call it, it's a horrible disease for sure, but it is really a matter of bad luck. If you believe in bad luck, I don't believe in luck personally, but if you want to believe in it, it is something that is very remote really for it to happen, because it is such a small minority of cases. Maybe, for example, let's talk about, one of the mutation that we'll talk about here. One of the genetic abnormality is the translocation that happened with CML, with chronic myelogenous leukemia, where there is, the T922. So part of the chromosome is going to be, translocated. This is why you call it translocation. It's a balanced translocation. So one part of, the 9 will go to the 22, and one part of the 22 will go to the 9. What happened is that, on the 9, there is actually the BCR, gene that's going to be, transferred to the ABL gene on the chromosome 22. So you will have what you call a fusion gene. Now, maybe actually the fragment that is going to be, transferred is going to be the BCR. But if the BCR actually is not just the pure BCR, it's having also some nucleotide on top of it. When it goes and tries to sit, next to or juxtaposed to the ABL, it will not result in a fusion gene, the BCR-ABL that have the tyrosine kinase. So it has to be purely BCR and ABL put next to each other and becoming juxtaposed to each other to create the fusion gene that is the BCR-ABL that has actually the ability or the effectiveness of a tyrosine kinase effect on the cell that will drive the cell into rapid cell growth. So it's a matter of really a remote chance, if you want to call it, for it to happen. All right. So what causes actually? Let's talk about the acquired causes. Heredity, it's on its own. There are a lot of genetic diseases that may result in this kind of actually a genetic insult to the cell that may result in neoplastic transformation. Some of them, are in the breast, some of them are in the colon, and so on and so forth. But here we're talking about acquired insults. what could actually drive the cell into becoming a cancer that, that could be gained from the environment. One of them is chemicals. We see that, the chemicals either itself is going to actually have a direct effect on the cell genome, or actually it's going to result in the production of a free radical that is going to have an effect on the cell genome. If you guys remember from the free radical lecture in the first part, free radicals have affinity for two parts, right, of the cell. What are they? The first one is the membranes, and the second one is the genome, right? So here it is actually. So how will it affect actually the genome? It will affect the genome because this free radical is going to try to steal an electron from the outer orbit, of those, genetic material, rendering those genetic material free radical again. So it's a vicious cycle. And those free radicals are going to, they are going to be abnormal. They are going to combine with other parts of the cell because they will drive also to bring, the number of the outer orbit to 2 again. And by doing this, they are going to damage other, parts of the genome, resulting in the possibility that one of those genetic insults may be, translated into a translatable neoplastic mutation. Radiant energy is a big actually topic. It has been known since the time of the Hiroshima, nuclear bomb, that actually there are ramifications for the patients who get exposed to the ionizing radiation. It is, if you think about it, it's a close call really between chemicals and radiant energy, the ionized radiation, which is the most common. Probably at the end of the day, the free radicals will win the day because they are the ones that are least to be counted, in terms of actually effect and count, on the cell's genome. All right, so the other reason why actually chemicals will be the most common is because they are part and parcel of the probably greatest weapon that was ever made, which is the cigarette, believe it or not. So the cigarette, 80 to 90% of cancers are due to the polycyclic hydrocarbons that are found in the tobacco smoke. Amazingly enough, people still smoke. There's no problem with that. Nobody will stop. Even though everybody they put on the, what they put on the cigarettes boxes. So bad habits are hard to break. This is something that you can take from here. All right. So radiation carcinogenesis. How does that happen? So it happens in a couple of ways. Either actually by splitting the water. The tissue is full of water. So it will actually, let's say that you're taking this beam and directing it against, this, site that has cancer, radiation treatment of cancer. In the process of doing so, one of the ways actually you're treating this cancer is that those cells have water. The water will be split into a hydroxyl group, the OH minus, which is a free radical. This free radical is going to wreak havoc on this cancer cell, not only on the cancer cell, but also on the tissue that are overlying this cancer cell. So this is why you end up actually seeing that patients who receive ionizing radiation, 10, 20 years down the road, they will come in with a second cancer. We have seen that actually with, at one point in time, thymomas used to be treated, the big chunk of thymoma, a big part or a big percentage of thymomas are benign thymomas. The thymic carcinomas is really one of the rarity, about probably 15%, 10 to 15%, if I recall the percentage. Now, thymomas used to be treated as a whole, benign or malignant, with radiation. Those patients used to come 10 to 20 years down the road with head and neck cancer development, a second cancer that will develop in them as a result of the radiation they received actually earlier in life. So thymomas, and thymic carcinoma are tumors that arise from the thymic gland. This is from the thymus. Okay. So example of that. Another actually, another set is when when you treat any kind of cancer with radiation, the treatment, and those patients will come in later not with an epithelial tumor, but rather with a mesenchymal tumor, with a sarcoma. Also about 10, 15 to 20 years down the road, they would come back in with a second, even worse prognosis, with sarcoma. So what does cancer do? You will see that it causes a lot of different types of genetic mutations, mostly like what you call wholesale kind of genetic insult. Usually the point mutations are very rare, to happen in the course of ionizing radiation, okay? Because usually it's a pinpointed kind of, change in the genome sequence. All right, so where else did you hear about ionizing radiation other than Hiroshima and other than Hiroshima, Nagasaki, and then where else? In the Soviet Union, right? In the 80s, if you guys heard about Chernobyl. But most recently, in 2009, there was another event. Fukushima. You know what is that? Not hear about Fukushima, right? That's actually Japan. When there was a tsunami that hit Japan, one of the installations that were hit was actually the radioactive, reactor. The nuclear reactor in Fukushima. And that actually reactor ended up spilling into the Pacific Ocean. And it's still spilling to this day, actually. This is something to keep in mind. Obviously, you guys are not into geopolitics, right? This is good for you. This is the best kind of thing you can do. All right, so I'm just giving you examples about radiation incidents, has nothing to do with anything else. All right, so what are the type of tumors that arise from this? I did mention to you the head and neck cancer that may happen, a couple of decades down the road. It could be actually also leukemia. Leukemia is known to be actually prone to arise from radiation. We have seen it that those who work in X-rays, in the radiologist technician, even with all the precautions they take in the form of lead kind of covers, there is so much radiation in those sites that they do have a high frequency of leukemias in those personnel, if you will, who work in radiation centers. We have seen it also, as I mentioned to you, in atomic bomb victims. Now we are seeing it becoming, or happening more frequently in patients in Fukushima, because this was about 11 years, ago. The most common type of leukemia associated with this is CML. All right, so the chronic myelogenous leukemia. Now, papillary thyroid carcinoma is also known to be, related to head and neck radiation. Lung cancer from radon gas in many areas in the US, radiant gas is in the soil, actually. They end up a lot of time before actually testing used to happen. So now let's say that you buy a piece of land in the US and you want to build. The first thing that they are going to do, actually, before they give you the license, they want to make sure that you're not building on a dump of radiant gas in the soil. The reason for this is that this radiant gas may actually go up in your house and affect the lungs of those people living there, resulting in lung cancer development. Where in the house do you think that radiant gas is going to have the highest concentration?
Microwave.
No,
Kitchen.
not kitchen, close by.
Bathrooms?
The bathrooms, right, very good. And where in the bathrooms? What part specifically in the bathrooms will it have actually the highest?
Near the toilet or drainage?
The washing, what do you call it, the baño, And what time of the day is it going to be the most actually when it comes up? Any idea? After the shower. After the shower, it was shown to be actually the time when this radon gas is going to be coming up from this area that is rich in radon underneath. Now, liver angiosarcoma, this is one of the, unfortunately, the tragedies that happen. One of our students here, unfortunately, has a relative who developed this rare disease following radio contrast material visualization of the arterial tree. The radioactive thorium dioxide was shown actually to result in angiosarcoma development in those patients who received this radio contrast material. So they will receive this radio contrast material that will light up the arterial tree, but unfortunately, many years, about 10 years down the road, you will see that the same patient is coming in with angiosarcoma of the liver. Of course, the use of this material has been discontinued after it was shown to be causing this. Osteogenic sarcoma, I did mention to you this, or not to you, actually, this is to year 3, sorry. So it was actually, like for those of you who like fancy watches, remember that at one point in time, those dial workers used to pay heavily for this, because when they were doing the dials, the radium dials of your watch, they were brushing, they were finishing actually the surface with a brush. And the way they do it is that they will actually, brush the surface, and then to wet it, they will not use water, they will use their saliva. So they will use their saliva, and then they put it on the radium again, and then back into their mouth. Eventually, those patients ended up actually developing osteosarcoma, osteogenic osteosarcoma. All right, so this is ionizing radiation. Now, viral oncogenesis, this is big actually. It's a big category, both RNA and DNA viruses. And now, like everything now you hear in the news is about viruses, right? So now, one thing actually I want to tell you about is how does actually a virus cause, a cancer? One of the things you need to keep in mind is that a virus is going to result in chronic inflammation, correct? And here's a rule, actually remember it always, any kind of chronic inflammation is a pre-neoplastic condition. If it goes on unabated, unstopped, untreated, it's going to result in the development of cancer at one point in time. Anything, whether viral causing it, whether bacteria causing it, whether a foreign body really causing a chronic inflammation, if you don't deal with it, if you don't treat it, take it out, for example, if it's a foreign body, at one point in time, it will result in neoplastic transformation. So this is one way for that to happen, for a virus to cause a cancer. The other way for that to happen actually is when the virus becomes integrated into the genome of the cell. That's actually another totally different story. And what happened in that case, it will go and cycle with the cell, and it will start to express what it harbors in its sequences. And one of the things that has been shown is that some of those viruses, harbor viral proteins that will be now made, as the cell is cycling, if you will, and they are going to be produced. Those viral proteins will be produced. It has been shown that those viral proteins have what we call a prohibitive or inhibitory effects on, for example, genes that are tumor suppressor genes. So they will go and knock down the tumor suppressor genes. What will that result in? That will result in disruption of the cell cycle and the likelihood that mutations may happen. One of those mutations may actually harbor, a cancer, or may develop into a cancer. Other viral proteins may actually go and, go and actually overexpress a proto-oncogene, have a direct effect on a proto-oncogene, overexpressing it, turning it into an oncogene, making the cell actually divide more, resulting in tumor formation. So a couple of ways. So a classic example actually of this is going to be the difference between hepatitis C virus versus hepatitis B virus, because hepatitis C does not get integrated as much as that of hepatitis B. So they do actually play with the genome for sure, but the one that gets really fully integrated in the genome is going to be hepatitis B. So in your opinion, which is going to be more likely to develop into cancer? So, both of them will cause chronic inflammation. So both of them are harboring this. So both of them have the ability, right? But then, hepatitis B comes on top of this and get integrated into the genome and starts actually to make, the different proteins that may play with the tumor suppressor genes or, the proto-oncogenes. So hepatitis B in this case will have a higher chance of development into cancer. Now, this may actually be ameliorated by the fact that actually hepatitis C is the infection that results in the most chronic cases of hepatitis. So see, like life always deals you two deals. It gives you one in hand and takes away something from you in the other hand, and vice versa. The same exact story right here. All right, so another big Another big thing actually in the viral oncogenesis is the HPV, human papilloma virus. Now they are doing, or they are making the rounds. We have a long list of different serotypes of papilloma virus. Anything below 11 is benign. So HPV 5, HPV 6, HPV 11, those are benign viruses. They may result in a papilloma development, but they will not result in a cancerous development, okay? Anything above that is going to be malignant. Any number you hear above HPV 11 is going to be cancerous. So HPV 16, HPV 18, HPV 31, 33, 34, 56, all of those are going to be actually cancerous, causing cancer. The number? Serotype. That's what I said, serotype. All right, so human papilloma virus in cell. Now it causes a long list of cancers. And of course, it has a lot to do with the sexual practices. So it has been shown to be actually related to anal, cancer, also penile cancer, also, tonsillar cancer, also laryngeal cancer. You guys know actually someone who got a laryngeal cancer recently, a very famous American actor? Probably not not your age, probably your parents' age, in terms of the age of the actor. Michael Douglas actually got a laryngeal cancer as a result of HPV infection. So as an example of that, of course, we now have a vaccine for the HPV. Have you guys taken the HPV vaccine in the immunology? Have you discussed it in immunology? You have not. I think you should. Doctors did what?
The lecture was postponed.
Postponed, okay. Let's hope that you do it. I'm going to ask you next time, inshallah. So let's hope that you will take it. Another star actually of viral oncogenesis is Epstein-Barr virus. Epstein-Barr is really big on different types of cancer. So in this one, you will see that, probably the star of the action is going to be the chronic inflammation that will accompany the infection. Now, of course, Epstein-Barr was known not really from cancer. It was known to be what? What do you call Epstein-Barr virus? What was the disease, the non-malignant disease that made Epstein-Barr virus famous? Say it again. Please speak up. Burkitt's lymphoma is cancer, right? It's a malignant tumor. Mononucleosis. What's infectious mononucleosis? What's the other name for that disease? Kissing disease. The kissing disease, that's right. All right, so Hep B, Hep C, we did talk about it very briefly. Human herpes simplex virus 8, the HHSV8, causing Kaposi sarcoma, one of the most dreaded tumors that came to be known with the AIDS epidemic in the homosexual population in San Francisco in the 80s. One of the first, actually, I believe that the whole epidemic came to be known as a result of the Kaposi sarcoma development in those patients who were immunosuppressed as a result of the AIDS, complex, and it was related to the HHSV8 infection. Of course, we knew about the HHSV8, much later on than the 80s. It happened to be known later on than early. There is also the HTLV1 known actually to be endemic in some areas of the Caribbean, and of course there is the big elephant in the room, the HIV, that does actually cause cancer on its own as well. So starting with the human herpes virus, I did mention that to you, the different types of virus, the ones we're going to be talking about, 16 and 18. In this case, related to the genitourinary tract, to the GU, especially the genital tract, actually, females, in the cervix and the vagina, causing actually squamous cell carcinomas. How does that happen? I did mention to you that both of them actually will cause chronic inflammation. So that itself actually is a pre-neoplastic condition. But then on top of it, you will see the overexpression of the viral proteins such as the E6 and E7. The E6 is going to inhibit the guardian of the genome, the P53, and the E7 is going to inhibit the retinoblastoma gene, the guardian of the cell cycle. both of them actually will, result in disruption of the cell cycle. The cell cycle, as you will see in the next lecture, is a very controlled operation. It's even though you call it the cell cycle, really, but in reality, that cell cycle is not moving. Most of the time, the cell cycle is stationary, is fixed. You will see that the cell will receive, let's say a growth kind of input, a growth hormone or a growth factor kind of signal. That is going to propel the cell cycle to move very briefly and then stop again. So the cell cycle propensity is to be stationary, to be stopped, rather than to be moving all the time. What will happen if you lift, and what is going to be the one that is going to actually keep the cell cycle in lock? What keeps the cell cycle in lock is actually the guardian of the cell cycle. In this case, it is the retinoblastoma gene. This is the lock of the cell cycle. If you take out the cell cycle lock, if you take out the retinoblastoma gene out, the end result is going to be making this cell cycle move again and again and faster amount. And as a result of that, there is no longer supervision of this genetic material in the checkpoints of the cell cycle, allowing for mutations to happen that could possibly harbor a neoplastically, inclined mutation that may result in the development of cancer. Okay? All right, so now the Burkitt's lymphoma. Again, what happened here is that you have increased cellular proliferation. That is going to actually make it likely that a special translocation may come to happen. That translocation is the T814. That is going to result in a translocation of the MYC, the c-MYC, from the 8 to the 14 chromosome. So the c-MYC is a proto-oncogene. When it is on chromosome 8, it is dormant. It is minding its own business. It moves when it, so do we have proto-oncogene in normal cell? Do we have proto-oncogene in normal cell? Absolutely we do. What do they do in normal cells? They are there actually to regulate growth, to regulate normal growth. So they move when they need to move, and they stop when you tell them to stop. What happened if you take this proto-oncogene that was sitting there on the chromosome 8 happy, and you put it under an active promoter on chromosome 14, you're going to turn this proto-oncogene into an oncogene. And that is going to drive the cell cycle faster and faster, and the proliferation more and more, resulting in a rapid tumor growth, what you call a high-grade tumor. So now you're getting to know what a high-grade tumor means. A high-grade tumor means that the cell is dividing faster and faster and giving rise to more of itself, right? Now, what happened as a result of that is that at one point in time, those cells will die as well. So like a party life. You party hard and then they die harder, right? That's exactly what's going to happen in those cells, resulting in the morphology that we'll talk about in a second. Other tumors arising from EBV is the nasal pharyngeal carcinoma, the NPC, a special tumor in the head and neck, a special form of the lymphoma, B-cell lymphoma in AIDS patients, and mixed cellularity type of Hodgkin's disease. Here's an example of the Burkitt's lymphoma. So Burkitt's lymphoma has two actually forms. One form or one phenotype that affects actually American patients, North American patients. That form is going to happen at the level of the ileocecal valve, and it's going to present into a mass that blocks the ileocecal valve. So those patients are going to present with intestinal obstruction. And then there is the endemic form of Burkitt's lymphoma, endemic because of its relationship to Epstein-Barr. And those actually are seen in Africa. As you can see, the patient is African here. So that's in patients in Africa, and in this case, you will see that the Burkitt's lymphoma is going to appear as a dominant mass in the jaw of those patients. You can see this mass right here, right? So in the jaw of these patients, they are going to present. Now, when you say the word lymphoma, you would think actually, that it affects lymphocytes, right? Or lymph nodes. So lymph nodes should be affected. So how come that we are saying a dominant mass. So what happened when it is a high-grade lymphoma, the way that this kind of tumor, present itself is going to present itself into a dominant mass. Whereas a low-grade lymphoma, you will see generalized enlargement of lymph nodes in a symmetrical fashion in the body. Okay, so just again to see it for next time, inshallah. So here you see this actually dominant mass in the patient. When you take a section of this mass, or you take a section of a lymph node affected with this Burkitt's lymphoma, high-grade lymphoma, you're going to see actually a very peculiar appearance. That's called the starry sky appearance. And the reason why you see the starry sky appearance, you should not see the stars of the starry sky appearance. The stars are actually the macrophages. So here what you're having, actually you're having what you call a tissue reaction. Because as a result of the rapid growth of this tumor, those lymphocytes are like, dividing fast, right? Dying fast as well, resulting in a lot of debris, cellular debris, that is going to incite the macrophages to come in, to take out the cell debris. What is the color of the macrophages? The cytoplasm of the macrophages. Its color is pale white. So if you contrast the color of the macrophages cytoplasm with the dark, nuclei of the lymphocyte, you see this poetic appearance of a starry sky that you see here. You see what I mean? You guys agree? Agree? Okay, good. All right. So hepatitis B, hepatitis C, as I mentioned to you, true, it is actually, proto-oncogene and the suppressor of the tumor suppressor genes, but there is actually definitely a differentiation between Hep B and Hep C. Hep B becoming part and parcel of the cell. Hep C, not so much, not as much actually, the word should be, not as much so. So resulting in the fact that, Hep C it's an interaction, it's an interplay between the viral infection and the hepatocyte. Whereas, with hepatitis B, it is both this interplay, this chronic inflammation that is ongoing, on top of the fact that actually, the hepatitis B have become integrated into the genome of that cell. The HHV6, the one that was discovered in those patients, actually, in a small epidemic of those, tumors, happened to be, found in AIDS patients in San Francisco in the 1980s. Is going to present itself first as a small plaque, then it will become a nodule, then it becomes an ulcer, eventually ulcerating, as you could see here. All right, usually of a bluish/reddish color in an AIDS patients. HTLV1 patients, especially from the Caribbean, are known to present with this kind of presentation, the HTLV1, and then there is the HIV and the primary CNS lymphoma. Now, so those are the viruses. The bacteria is not really far behind. Helicobacter pylori itself may result in a tumorous formation, resulting in a special form of a gastric lymphoma, again, as a result of the interplay, of the inflammation and what happened in the inflammation from the increased, cell death, cell proliferation, increased cell cycle, the likelihood that mutation may happen, resulting in a special, form of gastric lymphoma known as maltoma, mucosal associated lymphoid tumor lymphomas, known to be, a very low or grade lymphoma. This is actually why a lot of, infectious disease specialists will tell you that cancer is an infection. Where does that come from? Because sorry? Exactly. So it has been shown that those patients who actually, those patients who have the maltoma at the very early stages of their disease, if you treat them with antibiotic, the triple therapy and now the quadruple therapy for the H. pylori, it has been shown that you may reverse, believe it or not, you heard it from me, you may reverse the maltoma in the very early stages. Why does that, happen? They call it because it's a very weakly independent tumor, that you may actually be reversed once you remove the insult that resulted in its presence in the first place. Now, you cannot do that. I assure you that you cannot do that with gastric carcinoma. That may also come, or rise as a result of the chronic infection with Helicobacter pylori. chronic infection and treated infection, what they call partially treated infection or inappropriately treated infection, may all actually result in this kind of presentation. All right, how does a tumor present? The tumor may present in a lot of ways. One of the very classic way for a tumor to present is by compressing a nearby structure. Here's an example of that. A lot of times you will never see that. So this is really a rarity, okay, that this happened. And the only reason why it happened, just by looking at this picture, you will know that it happened because this tumor is silent, does not really produce any hormone. So production of hormones is going to tip off because the patient is going to come in with a clinical presentation, either as a result of an increase of a hormone or as a result of a decrease of a hormone, right? But when the tumor is simply endocrinologically, silent, does not produce anything, is not really compressing anything that will result, for example, in the interruption of the production of a hormone nearby, the end result is going to be that this tumor may actually grow silently until it reaches a large size. That's really bad news, because those type of tumors are going to present with compression kind of presentation. In this case, this is going to result in increased intracranial pressure. So this patient definitely is going to come in with a projectile vomiting, with intractable headache, with sleep abnormalities, and with compression, pretty much everything in that vicinity. Hydrocephalus, the whole 9 yards, everything that where it presses is going to actually result in a presentation. Now, if it's a GI tumor, let's say it's a colonic tumor in the right colon, those tumors are known to be prone to bleeding. And now if it's actually in the left colon where the lumen is smaller, those tumors are more likely actually to constrict and block and obstruct actually the colon. CNS tumors of the brain, we did talk about this. Pituitary adenoma, compression of the normal pituitary, okay? Compression of the optic chiasm, visual abnormalities, bitemporal hemianopsia, the tunnel vision, they come in. So it really depends on what is the tumor pressing on that is going to result in that kind of presentation. What time is it now, guys? 40? 43. Okay, we have a couple of minutes. All right, so for example, pituitary tumor, now hormone production, another actually for that to happen. Usually this is going to be relegated to benign tumors that most of the time retain their ability to make actually hormones. So pituitary tumors, with prolactinoma is known to be actually, the most common presentation is going to be sexual dysfunction in males and females. Sexual dysfunction and amenorrhea in females. If it's a growth hormone, you may see gigantism if it happens actually before puberty in children, and acromegaly in adults, and so on and so forth, depending on where is the tumor, what tissue is the tumor derived from. It may result in the production of the hormone that comes from those tissues. Or cancer cachexia, this is one of the very dreaded presentations of cancer, where you see that the patient of cancer have become skin and bone, really. That's it. The reason for this, one is going to be the suppression of the appetite center by the production of the TNF from the tumor cells and the macrophages that are brought to fight the tumor cells, what's known as the cachectin production. The other one is the increased mobilization of fatty acids from the adipocytes, because those cells actually, try to suck up as much as they can from the sources of the body, resulting in depletion of those resources, resulting in a presentation, with cachexia. Here's an example of that. I'm sure, probably, unfortunately, a lot of us have seen those kind of, presentations where you see the patient has turned into a skeleton, really, unfortunately. All right, so now what are the hematological presentations, with cancer? The most common of this is going to be the anemia of chronic disease. In this case, this is actually related to the production. Cancer, in a way, especially if it's of a low grade, low to moderate grade, you may consider it to be a chronic disease. The patient, there is no really any cure for it, and the patient is going to live, probably 4 or 5 years with it, resulting in increased production of the liver of hepcidin. If you guys recall that, hepcidin is going to be the reason for this anemia of chronic disease. Why? Because it's going to prevent the delivery of iron from the erythroblast. Sorry, the delivery of iron from the iron-laden macrophages in the bone marrow. So stop the delivery of iron from the iron-laden macrophages of the bone marrow to the erythroblast. So the bone marrow, if you do an iron stain on a patient with anemia of chronic disease, you're going to see that the bone marrow is loaded with iron. But this iron is not being transferred to the erythroblast to incorporate it into the erythroid production, okay? As a result of the increased production of hepcidin, remember that. And iron deficiency anemia, it is pretty common actually. One of the things that you need to remember, any patient above 50 who comes in to your office who is developing an iron deficiency anemia for the first time, you have to suspect that this patient has a GI malignancy, either a colon or a gastric malignancy. Remember that. Macrocytic anemia, again, like I mentioned to you, those cells are going to focus on the resources of the body. They are going to draw from the resources of the body. One of the things they are going to draw on is going to be the folate. They are going to draw on the folate. And in the body, there is actually limited supply, limited reserve of folate. How much folate there is in the body? Do you guys know? How much reserve do you have of folate in the body? Why not vitamin B12? And then still developing megaloblastic anemia. The reason for this is that folate is only, in the body, there is only 90 days worth of reserve. For vitamin B12, there is about 1,000 days worth of reserve, about three and plus years. So as a result of that, folate will appear more, much early on in this course. All right, autoimmune hemolytic anemia, sure, because some of those tumors, if you guys recall, are going to really throw off the immune system by developing an autoimmune response. And as a result of that, it may result in an autoimmune hemolytic anemia because those cells are going to be coated with antibodies. When they go through the spleen is going to recognize this antibody coating, and they are going to take those cells and, lyse them, what you call extravascular hemolysis, resulting in this hemolytic anemia. All right, so here's another example of this. That's actually when the tumor have moved into the bone marrow. If there is extensive metastasis of the bone marrow, or to the bone marrow, I should say, extensive metastasis to the bone marrow by any tumor really, or actually extensive neoplastic transformation of the bone marrow. If, for example, there is a leukemia that is arising from the bone marrow, such as a leukemia, for example, both of them are going to end up actually kicking all the normal elements of the bone marrow into the peripheral blood. And those normal elements will no longer be able to go back to the bone marrow. They will start to roam in the blood. And because they have what you call homing receptors, they are going to go back to where they were made before in embryologic life. That's going to be in the skin, in the liver, and in the spleen, resulting in a process known as extramedullary hematopoiesis. Now, this extramedullary hematopoiesis will do its best to put in, those actually offsprings, the RBCs and the white blood cells in the peripheral blood. But that's not going to happen, right? Why? Because you no longer have the normal house where those cells are taking their sweet time to mature. That maturation now is going to happen with the speed of light. As a result of that, those cells are going to reach the blood in a much more immature form than before. So you will see immature RBC in the form of nucleated RBCs. You may see immature white blood cells in the form of myelocyte, and metamyelocyte and promyelocyte, okay? Resulting in what you call actually left shift, resulting in a process known as leukoerythroblastic reaction. That's what it is. leukoerythroblastic reaction. So what's a leukoerythroblastic reaction? It's a left shift in the myeloid maturation, starting to show cells that are before the stage of bands, or showing actually more than 10% of bands in the blood, what we call bandemia. At the same time, you're also seeing nucleated RBC. So you're seeing also immature RBCs. The combination of the picture is a leukoerythroblastic reaction, telling you that the bone marrow of this patient is completely replaced with neoplastic process. Now, just so that you have a full picture, it may not be, again, like this is aside from this lecture. For example, let's say, someone in Riyadh have actually a very violent, car accident. That happened a lot, right? So the end result is going to be multiple fractures, right? If they have significant fractures in their body, as a result of the fact that healing now will be happening in those bones, they may have actually leukoerythroblastic reaction as well, okay? Let's say someone have actually a tuberculosis disease that spreads to the bone marrow, what you call Potter's disease, that also may do the same exact thing. So anything that has replaced the bone marrow may present with a similar presentation. In this case, it's a neoplastic process that have actually replaced the bone marrow, resulting in a leukoerythroblastic reaction. And you can see actually that, right? What is this here? So this is actually the body of the vertebrae, right? And here you have this big mass right here. What is that? This is a tumor mass that has metastasized to the bone marrow. Okay, you take a section of that, and you see the tumor cells that are embedded within this bony stroma. You see that, right? So every time you see blue, that's a tumor. Remember that. Why blue? Because that's actually the nucleus, which is really hard at work to give rise to the tumor cells. So this is the tumor right here, embedded in this, a bony stroma and also fibrous stroma right here. Okay. You guys want to stop and continue? But only 4 slides. We can do it next time. All right. All right. We'll start here. And I have how much? 68 questions. All right, Doc. Do you have questions?
There was a question about antibodies finding something outside the reference, but I'm not sure what you're talking about.
What does it say again?
What do the antibodies bind to? I think it's about hemolytic anemia, I'm not sure.
Right, so the antibody will bind to the RBCs. It will coat the RBC. This is why the spleen, which is actually entrusted in inspecting the RBCs, is going to take those antibodies coated with this, those RBCs coated with this antibody out. Anything else?
No. Oh, can you repeat the autoimmune hemolytic anemia?
Right, so again, as I mentioned to you, actually there are tumors, a couple of ways for the tumor to, throw off the immune system. One of them is going to be by simply creating an autoimmune response. One of the ways for tumors to create this autoimmune response is by actually coating those RBCs with antibodies that are directed against these RBCs. So now you have an RBC that is coated with an antibody. Every time, there is one organ in the body that is entrusted in inspecting all, blood cells, as it cruises through it. And that is the spleen. So the minute that the spleen will see that those RBCs are coated with antibodies, it will take it out, yank it out, and it's going to lyse it, resulting in extravascular hemolysis, which is really hemolytic anemia. Now you're calling it hemolytic anemia because the spleen, the macrophages in the fixed, cords of Billroth in the spleen are activated because, they have found those antibodies coating the RBCs, right? But, it's an autoimmune, derived. This is why you call it autoimmune hemolytic anemia. Right?
What is the role of hepcidin in anemia prone disease?
Right. So hepcidin is going to stop. It's going to halt the delivery of iron from the iron-laden macrophages to the erythroid series, to the erythroblast, if you will, to the erythroid precursors.
Okay. Can Dr. repeat myelocystic anemia?
Sorry?
The last from the myelophthic anemia.
My hemolytic anemia again?
No, the last one, myelophthic.
Myelophthic anemia, right. So that's actually what happened when you start to see that there is metastasis to the bone marrow. So metastasis to the bone marrow, that means actually that the whole bone marrow have become replaced, or a big part of the bone marrow have been replaced by a tumor in this case, resulting in the fact that actually those bone marrow elements now will be made not in the bone marrow but in other sites outside the bone marrow. In the process of doing so, you will be producing a lot of immature cells. Now, those immature cells will be ineffective cells, meaning you will have less of the mature RBCs, less of the mature white blood cells, right? And less of the mature platelets as well. So you will see trilineal, really, kind of, hypoplasia, if you will, because now the bone marrow elements are maturing outside the bone marrow. The end result will be actually anemia. In this case, we're calling it myelophthic anemia because of the replacement of the myelo, the bone marrow. All right, that's it. Thank you very much. All right, so do I close? Just simple close.